Everyone, my name is Nazliah Azzahra. First, I would like to apologize for not being able to attend in person due to my health condition. And today I will be presenting my thesis proposal titled Understanding Iodine-131 Uptake, Clearance, and Retention in Thyroid Cancer Patients. My research is a literature review research. And before I begin, I would like to thank my supervisor, Dr. Jake and Dr. Pageman, for the guidance, help, and support throughout this project. So a little bit about thyroid cancer. So a little bit about thyroid cancer. So thyroid cancer is the most common endocrine cancer. With data from 2020 alone, there were over 500,000 new cases worldwide, with a majority of the patient being female. But despite these increasing incidence, the thyroid cancer is considered to be one of the cancers with highest cure rates, with 5-year survival rates of thyroid cancer is about 98.4%, and radioiodine therapy as part of the treatment achieves success rate around 87% with a single dose alone. However, Fong et al. In 2001 reported a case of delayed radioiodine clearance in a 51-year-old thyroid cancer patient. So the patient showed a prolonged iodine uptake in the right upper quadrant of her abdomen 10 days post-treatment with a dose of 3.3 gigabecquerel. And imaging showed there is a localized uptake to the gallbladder. And this case raises important questions about what causes this delayed clearance and what might happen to the patient if radioiodine remains in the body longer than expected, what side effect could develop, and more importantly, how can we prevent it, or what should we do if that case is still occur, even if we have tried to prevent it. And therefore, this study aims to identify predictors of abnormal iodine-131 clearance in thyroid cancer patients to develop recommendation for managing prolonged radioiodine retention. Some of the questions that need to be answered are what factors that significantly affect the clearance of iodine in the body, and which organ are likely to be affected if delayed clearance occur, and how many doses that organs are going to receive. And last one, how can we anticipate or prevent such cases? So a background about thyroid and thyroid cancer therapy. So thyroid is endocrine tissue that hugs in front of our trachea, and it plays a really important role in metabolism. It produces three main hormones. It produces three main hormones: T3 or triiodothyronine, T4 or thyroxine, and that plays a role in digestion and brain development and growth. And the last one is calcitonin, that plays a role in regulating the calcium inside the body. And the production of this hormone requires iodine, and to support that, thyroid gland actively traps iodine. This iodine uptake capability of thyroid cells from the basis for radioiodine therapy in thyroid cancer patient. So usually, the patient will are going to receive several steps of treatment to cure the cancer. First is thyroidectomy, or surgical removal of thyroid gland, and then followed by radioactive iodine therapy using iodine-131. And lastly, because the thyroid gland already removed, the patient will have to receive synthetic hormonal replacement. So iodine-131 is usually administered orally in a capsule as sodium iodide, and once ingested, the iodine are going to dissolve in the stomach, and it will be absorbed in the small intestine, enters the bloodstream, and the thyroid gland or any metastasis are going to take on the iodine. And lastly, the iodine are going to eliminate it through the kidneys, and the rate of this clearance can vary across patients. And in fact, the body can retain the radioiodine longer than expected. And this clearance rate depends on patient psychological factors. Some of the factors are going to impact. First is renal function, yeah, because 90% of administered iodine is going to be cleared by the kidneys. And one study showed that patient with renal disease, particularly end-stage renal disease, will show 5 times lower clearance in radioiodine. And for now, there are two parameters used to assess kidney function. First is creatinine level, and the second is estimated glomerular filtration rate. So creatinine level is basically a waste product by the muscle metabolism, and kidneys will filter this from the blood, excrete it in urine. And if there is high serum creatinine levels in the urine, it means the kidney are not filtering the blood effectively. The second one is eGFR. It measures how well the kidneys are filtering the blood. The normal value is 60 milliliter per minute, and lower values will indicate impaired kidney function. The second factor is TSH, thyroid stimulating hormone or thyrogen elevation method. So after patient going for thyroidectomy, the patient are going to receive synthetic hormone to replace the thyroid hormone. But before the patient going for radioiodine therapy, we need to elevate the thyroid level. So the thyroid gland will take as much as iodine as it can, and it can be achieved through two different methods. The first one is stopping thyroid hormone fields, and the second one is injecting recombinant human thyroid stimulating hormone. And so basically, in withdrawal methods, the patient will stop taking synthetic thyroid hormone for like 2 to 4 weeks or even months, and it will trigger the pituitary gland to increase the TSH level. Meanwhile, for the second method, patient can still take the synthetic hormone pills, and patient will receive injection of thyroid over like 2 days. And the difference in clearance time between these two methods is mainly due to difference in kidney function. So the withdrawal method make the body in hypothyroid conditions, which slows down the metabolism and also the kidney performance. But in contrast, in the stimulation method, the patient can continue taking the thyroid hormone, so it won't cause the body in hypothyroid conditions. And then the third the third factor is presence of metastasis. So the metastasis thyroid tissue, like those in the lungs or bones, can actively take up the iodine just like normal thyroid tissue. So the more metastasis present, means the larger proportion of iodine is trapped in the body, and this leads to slowing overall clearance of iodine. One study by Klein et al. Shows that the patient with lung and bone metastasis has effective half-life of 24 hours, and the patient with no metastasis has effective half-life of 13 hours. The last possible, the last possible factors is sex and age, but there are still debate whether age and sex statistically influence the clearance rate of the radioiodine or not. And when the radioiodine retention occurs, there are several organs that are at risk. First is salivary gland and lacrimal glands or tear glands. Second is the bladder, and also the gastrointestinal tract, bone marrow, and of course sites of metastasis like lung, bone, and etc. So right now, the papers available are scattered and within two different focus. There are papers that only reported the effective half-life of iodine. It also report factors that affecting this clearance, and some paper, only a few paper, report organ-specific absorbed dose. And the second type of paper is clinical cases paper. So this report individual cases and what clinical intervention or management that they have done to cure this patient. And usually this report is lack of psychological data like the creatinine level or GFR level. So what I will be doing is I will be doing literature review on investigating factors that significantly influence the iodine uptake. And then second, I will be looking for cases related to radioiodine retention and what side effect occurs due to that retention. And then identify what factors affect the delayed clearance in each cases, if there is any. And then what treatment they have done to prevent or to treat the patient in that cases. Database will include Science Direct, Web of Science, PubMed, and OneSearch. Some of the keyword that I will be using like renal clearance, renal function, residence time, also biokinetics and biodistribution. These are some example of Boolean search string that have been used. So the inclusion criteria for this study only assess studies that involve human patients and use radioiodine-131 as for diagnostic or therapeutic purpose. Studies that include patient-specific factors and related to effective half-life or residence time, peer review articles published in English, and no restriction of on publication year to allow older paper that reports retention to include, because retention cases is really rare. And then this study does not need ethical approval because it won't involve any human or animal subject. And conclusion, to conclude, so the radioiodine therapy is generally safe, but the clearance times really varies between patients. And this influenced by psychological factors like renal function, the age, sex, and etc. And if there is a delayed clearance, radiation exposure, it can increase the radiation exposure and cause health risk to the patient. But most studies now only focus on 1 to 3 factors like the relation of sex and creatinine level on patient's clearance, and there is a need for research that combine multiple predictors and offer preventive strategies. All right, that's all for me. Thank you all for listening. Does anyone has any question?
Thanks, Nazliah. Questions? from the room. Kaylee, might speak up a bit.
Thanks for that talk. It was very good. I just had a question about the range, the time range of the study that you're looking at. So you mentioned that you don't have a range. Has the treatment for thyroid cancer changed a lot in the last 25 or so years, or has it been constant since that study you showed from 2001?
All right, thank you. So from what I've read, the treatment does not differ that much, except for the dose. So for what I've read, now the dose that are given to the patient already reduced. Like usually the patient are treated with 7 gigabecquerel dose, but now it only like 3 gigabecquerel or 5 gigabecquerel.
So it's all fairly comparative. You read them all in your literature review.
Sorry, actually, I cannot hear you that well.
So the dose is a little bit different. So are they still all relevant to include in the literature review?
Oh, I think it's still relevant. Because the only difference is the dose, and usually what I will be included from previous paper is only the retention case. I will be only looking for retention case.
Thank you.
The factor is weight, so those based on weight. So Roger, you have a question? Roger Winter.
Yep. Yes, I have. Thank you. This was a very, very important work, Nazliah, and congratulations on your presentation. You presented it very clearly. I've got just a couple of questions. The first one is it's important in part because prolonged retention will increase the absorbed dose to vital organs, radiosensitive organs, presumably in very complicated ways, depending on where the retention occurs and for what reason. Are you going to include in your study any information that you can get from the literature on the burden, on the radiation burden of prolonged retention? Because presumably that's one of the major reasons for studying it in the first place. And I think that's, if you can get that information from at least some of the studies, I think that's important. And secondly, have you spoken with, I'm guessing that the best contact would be Sir Charles Gardner, but that may not be the case. Have you spoken with any of the endocrinologists and nuclear medicine physicians who administer the doses, and of course the medical physicists who help out? Because although there may not be precise data available from such conversations and so forth, you might get some kind of anecdotal feel from their experience as to what the important aspects are. Sorry, that was a bit long. The first one was about dosimetry using MIRD or some formula. And the second one was clinicians.
So probably I'll answer the second one. Roger, after Nazliah said first.
All right. So Roger, the for radiation burden that you mentioned, does that mean the absorbed dose to each organ?
Yeah, pretty much. Yeah, that's what I was thinking. If you have extended retention, if you have delayed excretion, then you would expect the radiation burden to key organs to be increased. And I just wonder what the literature says about, as a subset of the literature that you're looking at, I just wonder what the literature, the published literature says about that particular topic.
Wait, okay. So from what I've read, only few paper reported the absorbed dose, and for clinical report that report the delayed delayed clearance. They didn't report any absorbed dose, only like side effect and what clinical action they have done and such a thing.
Okay, thank you. I just think that that's an area that you should look at.
Thank you.
There may not be a lot of literature on it, but I think you should look for
Yeah.
it if you can find it.
Yes,
Yeah,
thanks
because
for
actually,
Yes. Sorry. So just to answer the second question, at the beginning of this project, we started to negotiate or discuss these things with clinicians, nuclear medicine, Mario and Rick were involved with this, but he said they're not happy to share any information from Charles Darwin Hospital. That's why we switched to literature review, not to have access to real data from the patient, which is unfortunate, but I understand the concern. So maybe after this project is done, we can convince them that's a good investigation if we go through our own system and check it. But if not, we can stop the research, do our own. We will do our best to mention for the entire community what would be the impact and how to prevent, and after even as Nazliah mentioned, even after prevention, if this happens, what to do action.
Thank you.
Thank you.
thank you, Benjamin.
Yes, Joel has a question.
Yeah, thanks a lot, Nazliah. Yeah, great presentation. Just wanted to ask, do you think, have any of the studies you've seen, or do you think there's scope for investigating any image-based features that could be indicative of iodine uptake or clearance? Has that been looked into at all, as you've seen, or is that something you'd want to look into, like if there's diagnostic CTs used in the first place to diagnose the presence of the thyroid cancer?
Sorry, I cannot hear it clearly. Do you mind to repeat your question?
The question was, are there any imaging-based features that might predict iodine clearance?
The only imaging based is using gamma camera.
Yeah, are there any features from a gamma camera, so like a SPECT image, for example, that might predict iodine clearance?
Oh, I haven't read anything about that before.
Yes, it's a good question, Joel. We can for next semester, because we still have research to do, 3 more units. It's good to focus on the diagnosis using nuclear medicine, CT scan, or even ultrasound. Let's check those.
I was also just wondering if there'd be scope for investigating any non-clinical studies, even just as it goes for understanding physiological uptake. I don't know if there'd be any studies more in the context of like even mining or emergency relief workers, estimating dosing in those fields, or like animal studies, even just to understand uptake and clearance, or does it need to be only thyroid cancer patients?
I think so the radioiodine usually used in hyperthyroid patient or thyroid cancer patient. So I think both of these patients are available for this study.